dermatologists, we're trained to recognize subtle detail, and we may be the first or really the only physicians to pick up on the seemingly minor cutaneous manifestations of underlying nutritional disease. We are extremely skilled at examining not only the skin, but the hair and the nails, which are often the first locations these deficiencies manifest.
In this episode of Dermatology Weekly, Dr. Bridget Shields joins Dr. Vincent DeLeo to discuss the dermatologist's role in managing nutritional dermatoses in hospitalized patients. Welcome to episode 71 of Derm Weekly. I am the voice of the show, Nick Andrews. Remember, you can find links to the news stories in the show, along with an outline of the peer-to-peer portion in the show notes, guest biographical information, relevant disclosures, and contact information for Dermatology Weekly is there as well. Coming up in peer-to-peer, Dr. Bridget Shields and Dr. Vincent DeLeo discuss nutritional dermatoses. But first, the latest in dermatology news. We begin today with how lifestyle changes that patients experienced during the pandemic could impact their skin. New research reports finding no direct association between the novel coronavirus and skin lesions on the hands and feet of young people. The researchers noted that this finding raises the possibility that other contributing factors, like lockdown conditions. The new finding comes from two prospective case series from Europe published in JAMA Dermatology. There have been reports circulating about chickenpox-like vesicles, urticaria, and other skin lesions among patients with this coronavirus. Acute acroischemia has been cited as a potential sign of infection in adolescents and in children. In one of the studies aforementioned, researchers explored this association in 20 patients between the ages of 1 and 18 years who presented with new-onset acral inflammatory lesions in their hands and feet at La Fe University in Valencia. The study took place during Spain's peak quarantine period, which was in April. The researchers identified acral erythema in 6 of the 20 cases, dactylitis in 4 cases, purpuric maculopapules in 7 cases, and a mixed patter in 3 cases. Serologic and viral testing yielded no positive results for the coronavirus or other viruses, and none of the patients exhibited COVID-19 symptoms. In other findings, 45% of the patients had history of vascular reactive disease of the hands, 75% reported walking barefoot in their homes while staying at home. Only 2 of the 20 patients reported taking medications. There were 6 patients who had a biopsy. In those patients, the findings were characteristic of chilblains, which, for the authors, confirmed the clinical impression. They concluded that they could not show a relationship between acute acral skin changes and COVID-19, noting that other studies with improved microbiological tests or molecular techniques aimed at demonstrating the presence of the novel coronavirus in the skin may be needed to clarify. The second case series, published in JAMA Dermatology, included 31 adults at a hospital in Brussels who had recently developed chilblains. This series also looked for connections between the novel coronavirus and chilblains in April 2020. Most of the patients were in their teens or their 20s. Lesions had appeared on hands, feet, or on both extremities within 30 days of consultation, which presented as erythematose or purplish erythematose macules, occasionally with central vascular or bullous lesions or necrotic areas. The researchers obtained biopsies in 22 patients and confirmed the diagnosis of chilblains. And of the 15 with immunofluorescence analyses, 7 patients were found to have vasculitis of small diameter vessels. The researchers reported that of the 31 patients, 20 reported mild symptoms that are consistent with the novel coronavirus. However, none of the RT-PCR or the serologic test results showed signs of the coronavirus in all 31 patients. Is it possible that the serologic testing was done too soon? Well, the authors addressed that, writing that because some of the patients had experienced chilblains for more than 15 days at the time of inclusion, they could reasonably exclude the possibility that serologic testing was done too soon. They also report that they did not find eosinopenia, lymphopenia, and hyperferritinemia, which have been associated with COVID-19. Changes in lifestyle conditions during the pandemic may explain the appearance of these lesions, according to the authors of both studies, who mention that walking around in socks or bare feet with reduced physical activity could have indirectly led to the development of skin lesions. Dr. Ignacio Torres Navarro is a dermatologist with La Fe University, and he was the Spanish study's corresponding author. In an interview with MD Edge, he said that it is possible that young people have less severe disease and they have a delayed reaction to the virus. He went on to say that their feet may lack maturity in neurovascular regulation and or the eccrine glands, which can happen in other diseases. Dr. Claudia Hernandez is in the Department of Dermatology and Pediatrics at Rush University Medical Center in Chicago, and Dr. Anna Brucker is in the same departments at the University of Colorado. They authored an editor's note in which they wrote that it is still unclear whether a viral cytopathic process versus a viral reaction pattern or other mechanism is responsible for COVID tos. They also wrote that the lack of confirmatory testing and the reliance on indirect evidence of infection complicates this further. They added that dermatologists must be aware of the protein and cutaneous findings that are possibly associated with COVID-19, even if our understanding of that remains incomplete. And it looks like there are benefits to integrating dermatology into oncology centers. Indeed, incorporating skin toxicity protocols at a cancer center significantly increased the rate of prophylactic treatment for rashes that resulted from cancer therapies, as well as lowered the risk of interrupting or changing the dose of cancer treatment. This is according to the results of a retrospective study of 208 adults who were treated at the Dana-Farber Cancer Institute in Boston and at other sites. The study was published in JAMA Dermatology. In the study, researchers compared adherence to protocols at Dana-Farber before and after the 2014 and 2015 initiation of a skin toxicities from anti-cancer therapies program, or the STAT program, at Dana-Farber. STAT was established by the Department of Dermatology at Dana-Farber back in 2014. The study population included 208 adult cancer patients with colorectal cancer, head and neck cancer, or cutaneous squamous cell cancer, treated with at least one dose of cetuximab. The average age of the patient was 62 years old, and the majority of patients were men. The STAT program included the integration of 9 oncodermatologists in the head and neck, genitourinary, and cutaneous oncology clinics for 7 of 10 cancer treatment sessions per week, as well as the creation of urgent access time slots in oncodermatology clinics for 10 of 10 sessions per week. So let's look at some of these results. Overall, significantly more patients were treated prophylactically for skin toxicity at the start of cetuximab treatment in 2017 compared with 2012 after the initiation of the dermatology protocol. 47% of patients got prophylactic treatment in 2017 and 25% got prophylactic treatment in 2012. Additionally, the preemptive use of tetracycline increased significantly from 45% to 71% between the two time periods. This was also true of the use of topical corticosteroids, which increased from 7% to 57%, while the use of topical antibiotics decreased from 79% to 43%. Rates of dose changes or interruptions were significantly lower among those on prophylaxis at 5% versus 19%, which was a 79% lower risk. Patients who were treated prophylactically were 94% less likely to need a first rescue treatment and 74% less likely to need a second rescue treatment for rash. And finally today, Democrats and Republicans appear to agree on something, and that thing is face masks. Most Americans support the required use of face masks in public, along with universal COVID-19 testing to provide a safe work environment during the pandemic. This is according to new data from the Commonwealth Fund. Results of the study show that 85% of adults believe that it is very or somewhat important to require everyone to wear a mask to work, when shopping, and when on public transportation. The survey was conducted from mid-May to early June in 2020 and included nearly 2,300 respondents. The survey showed that regular COVID-19 testing for everyone was supported by 81% of the sample as a way to ensure a safe work environment until a vaccine is available. Perhaps most interestingly, support on both issues was consistently high across racial, ethnical, and political lines. Here are some of those numbers. Mandatory mask use gained 91% support among Black respondents, 90% among Hispanic respondents, and 82% among whites. There was a greater distance between the political parties, however. 70% of Republicans and those who reported to lean Republican supported mask use. This is compared with 95% of Democrats and those who reported leaning Democrat. 66% of Republicans and those leaning Republicans said that it was very and or somewhat important to ensure a safe work environment, as did 91% on the other side of the aisle. Hispanics offered the most support by race or ethnicity, with 90% saying that testing was very or somewhat important, compared with 86% of Black respondents and 78% of white respondents. 2/3 of Republicans said that it was very or somewhat important for the government to trace the contacts of any person who tested positive for COVID-19, a sentiment shared by 91% of Democrats. That type of tracing was supported by 88% of blacks, 85% of Hispanics, and 79% of whites. And now you're all caught up on the latest in dermatology news. Remember, you can find links to those stories in the show notes. You can email Derm Weekly at podcast@mdedge.com, and you can interact with us on Twitter at mdedgederm, and you can find the links to both of those addresses in the show notes as well. Dermatology Weekly, we'll be right back. Welcome back to Derm Weekly. It's time now for Peer to Peer. Please welcome the host of Peer to Peer, Dr. Vincent DeLeo.
Today we're talking to Dr. Bridget Shields about nutritional dermatoses in hospitalized patients. Dr. Shields is from the University of Pennsylvania Perelman School of Medicine in Philadelphia. Thank you so much for joining us today, Dr. Shields.
Thank you so much for having me. I'm excited to be here.
So let's get started. So, Bridget, why do dermatologists need to have a deeper understanding of nutritional disorders?
Sure. So I'll start by defining malnutrition, which includes deficiencies, excesses, or imbalances in a person's intake of energy and/or nutrients. So our review focuses on undernutrition in hospitalized patients, which occurs actually relatively commonly, but because it may develop slowly over months to years, it often goes unrecognized. As dermatologists, we're trained to recognize subtle detail, and we may be the first or really the only physicians to pick up on the seemingly minor cutaneous manifestations of underlying nutritional disease. We are extremely skilled at examining not only the skin, but the hair and the nails, which are often the first locations these deficiencies manifest. I think commonly inpatient teams and hospitalists are so busy managing other parts of a patient's care. As dermatologists, we can really step up and help identify clues that lead to the diagnoses of nutritional deficiency. We know now that early identification and treatment of nutrient deficiencies can drastically improve patient morbidity and mortality and decrease system-wide healthcare costs. Further, there are some nuances to the workup of nutritional deficiencies, and we outline these in our review. So dermatologists can help guide appropriate diagnostic testing and subsequent supplementation. I think ultimately, not only understanding the cutaneous manifestations of nutritional deficiencies, but really understanding the underlying pathophysiology of these conditions can help us understand and counsel on how supplementation should occur and how long it may take for improvements in both systemic health and the skin specifically.
You have a very extensive table in your article on predisposing risk factors for nutritional disorders, which, by the way, I would recommend to all of our listeners, something good to print out and keep with you forever. But can you highlight some of the more common ones in your table?
Yeah, and I think this is a really important question. So if dermatologists are aware of the patients at risk for nutrient deficiencies, it is much easier to make these diagnoses. Some really common medical conditions serve as risk factors that I think we routinely overlook as providers. For example, inflammatory bowel disease affects over 3 million people in the United States alone, with increasing prevalence worldwide. Inflammatory bowel disease, and specifically Crohn's disease, because if you recall, that can affect the entire gastrointestinal tract, serves as a risk factor for almost every macro and micronutrient deficiency we described in our review. Approximately 15% of patients with inflammatory bowel disease experience zinc deficiency worldwide, and in Crohn's disease specifically, zinc deficiency has been associated with active intestinal inflammation, increased risk for hospitalization, increased risk for intestinal surgeries, and increased rates of disease-related complications. Now, similarly, conditions like celiac disease, which affects about 1 in 100 people worldwide, so also common, can predispose to a variety of nutrient deficiencies, and the skin may be the first clue to this diagnosis in these patients. I think personally, patients with these underlying malabsorptive gastrointestinal disorders should be routinely screened for nutritional deficiencies, as they're extremely common in these patient populations. I'll also highlight chronic alcohol use and substance abuse, which serve as important risk factors for nutritional deficiency. And identification of these factors can ideally be elicited through careful history taking or an admission urine drug screen. And then finally, I'll highlight popular dietary habits such as veganism or vegetarianism, which may predispose to nutrient deficiencies. But I think we rarely inquire about a patient's dietary habits during hospitalization, and this is something we probably should really do more often. Ultimately, it comes down to understanding the whole patient, including their medical history, their dietary habits, and any ongoing medication use. I find that undernutrition really emerges when a series of risk factors occur in combination, tipping the balance towards that deficiency. For example, take a strict vegan patient with underlying hypertension on an ACE inhibitor who develops an acute severe infection. We know veganism, diuretics, and a sudden catabolic state, as we see in widespread infection, all serve as independent risk factors for something like zinc deficiency. And so I think we see undernutrition manifest when there is a systemic disruption in homeostatic state. One of the reasons, as you alluded to, that we put together such an extensive table is because it's nice to have this as a resource to pull up when seeing patients to assess their risk factors and also assess cutaneous and systemic manifestations of undernutrition.
That's fantastic. Now, can you talk to us about the cutaneous manifestations that we as dermatologists should keep at the top of our mind when we're thinking about this in our patients?
Sure, yeah. So there are a few key nutrient deficiencies that I think dermatologists see relatively commonly, but may miss if they don't present in a classic fashion. So I'll try to highlight those. The first is one we've already talked about a little bit, which is zinc deficiency. And to provide a little background, within keratinocytes, zinc is critically important to normal proliferation and suppression of inflammation. Zinc also plays an important role in cutaneous immune function. Zinc deficiency, or acrodermatitis enteropathica, typically presents in infancy. However, this condition should really be considered in older, critically ill or chronically ill patients, as catabolic states increase the risk for zinc deficiency. Now, this condition typically presents with sharply demarcated, often scaly, pink-red, eczematous, or psoriasiform plaques that can evolve to erosion. Lesions are found preferentially in acral and periorificial sites, but when the inguinal folds are predominantly affected, acrodermatitis enteropathica can mimic things like tinea cruris, candidiasis, inverse psoriasis, or even Paget's disease, and a skin biopsy really should be considered in these patients. Next, I'll talk just briefly about iron deficiency, which is extremely common and can often first be identified by pallor of mucous membranes, and then that evolves to angular cheilitis and glossitis. I will point out that you cannot identify a specific deficient nutrient when you see a patient with glossitis alone, because B vitamin deficiencies can also present with glossitis. But I think the oral mucosa can provide important insight into the patient's underlying metabolic picture and really their overall systemic health. Alopecia can be another important marker of underlying iron deficiency, as can koilonychia or spoon nails, which we have a nice image of in our text. Iron deficiency as a whole is a really great example of why a thorough examination, including assessment of mucosal surfaces, hair, and nails, is so important in hospitalized patients. And finally, I'll just highlight vitamin B12 or cobalamin deficiency, which is not as common as the others I discussed, but I want dermatologists to be aware of the presenting cutaneous features of this disorder. The nails can be a major clue to this diagnosis, as patients may exhibit brown, blue, or black hyperpigmentation of the nails. Sometimes this pigmentary change solely affects the nails, and sometimes there's associated involvement of acral sites, palmar creases, oral mucosa, or the intertriginous sites, and this can mimic Addison's disease. So basic science studies have previously shown that B12 deficiency actually induces oxidative stress in pre-existing melanocytes, and this results in increased melanin in the basal epidermis, which likely accounts for this hyperpigmentation that we see clinically.
That was really a wonderful discussion of what we as dermatologists should be looking for when we're thinking about evaluating the whole patient. But what do we do when we see this skin disease? How do we treat nutritional deficiencies?
Yeah, great question. So as we allude to in our review, many critically ill or hospitalized patients are in a catabolic state. This increases their energy expenditure and also increases their protein requirements. Additionally, there's an anorexic effect of systemic inflammation. So sick patients are usually taking in less calorically or eating less than they do at baseline. I think working with a nutritionist can be really important to ensure a patient has appropriate macro and micronutrient composition of any supplementation provided. Now, treating the underlying deficiency will simultaneously treat the skin disease in most cases. Many patients have multiple coinciding nutrient deficiencies, and so really identification and supplementation of any contributing deficiency is extremely important. And then, of course, exploring and addressing the underlying cause of the deficiency in the first place and understanding the patient's need for short-term versus long-term supplementation is important for preventing recurrences and improving patient overall health. I think a lot of people will ask about skin-directed topical therapies, and I think these can be useful in the right context. For example, xerosis is a common feature of many nutrient deficiencies, and we'll often add things like thick emollients and even occasionally topical corticosteroids if we think there's an inflammatory component to the cutaneous disease specifically. But I want to highlight that these topical therapies should not be used alone without the associated nutrient supplementation.
So, Dr. Shields, this has been a marvelous discussion, but as you noted, the article is entitled "In Hospitalized Patients." What would you say to our listeners to make them understand a little better how this plays into their normal clinic days?
Yeah, that's a great question. And I actually can add a little more context on that because I really think the role of nutrition in skin disease remains relatively unexplored at this time. However, I do think it will become increasingly important as we learn more about how macro and micronutrients may influence things like genetic and epigenetic changes in the skin. Nutrition is probably one of the safest and most easily modifiable parts of a person's systemic health, and ultimately we need larger, more rigorous studies on how nutritional manipulation may impact the skin and serve as an adjunct to therapy with more traditional medication regimens. As you just highlighted, this review focused on undernutrition, and I think we should be aware of these manifestations early on in typical clinical visits before patients are hospitalized. Similarly, I think another review could actually be written on the cutaneous features of nutritional excess and altered dietary habits. As I'm sure you're well aware, new dietary trends are consistently emerging. Things like the ketogenic diet, these things do impact the skin, and obviously dermatologists should be aware of these conditions as well. Overall, I really just appreciate you guys having me on to discuss this topic in more detail. It's something I obviously think is incredibly important, and hopefully it will help dermatologists feel more comfortable recognizing and treating nutritional deficiencies.
So thank you again for joining us.
And that concludes episode 71 of Dermatology Weekly. Derm Weekly is produced by MDH Dermatology editors Elizabeth Meshkati and Melissa Sears. The host of the peer-to-peer portion of this episode was Dr. Vincent DeLeo. Our guest this episode was Dr. Bridget Shields. Peer-to-peer is produced by Melissa Sears and Tyler Mundek. The news portion of our show is produced by Elizabeth Meshkati and written by myself. Stories this week were originally published online at MDH Dermatology and written by Jennifer Lubell, Heidi Spleet, and Richard Franke. All MDH podcasts are produced by Medscape Vice President Dr. Ivan Aransky, as well as MDH Executive Editor Kathy Skarbeck. Our social media is produced by Kyla Clark. The show is engineered, edited, and mixed by Tyler Mundek. I'm the voice of MDH Podcasts and the host of Derm Weekly News, Nick Andrews.